Hey everyone, and welcome to the Neurology for the Non-Neurologist lecture on interpreting neuroradiology. Um, Radiology is really actually a pretty essential part of neurology. I guarantee you're going to be seeing imaging pretty much every day on your neurology rotation, and so it's just a really great skill to understand the basics of. So let's dive in. As part of my usual disclaimer, remember Neurology for the Non-Neurologist, built to help you succeed on neurology rotations, but it's not an all-encompassing review of the entirety of neurology. All right, guys. So like our other videos, this is going to be broken into two different, more digestible videos. In the first half, we'll talk about CT imaging, CTAs, and then MRAs. And then in the second half, we're going to focus on direct angiography and CT perfusion, which are two tests you'll become more familiar with on our service. And then the famous brain MRI, which is probably the hallmark of neurologic imaging. You'll note I don't talk about spinal imaging in here, just because I wasn't going to be able to fit in here, but we will see some spinal imaging on service as well. And then finally, as always, we're going to wrap it up with a few review questions. So let's get into it. Before we talk though, just with any type of imaging, make sure you can recognize axial or transverse cuts versus a sagittal cut versus a coronal cut. I'm not going to belabor this point, but if you aren't familiar with it, I would just pause the video quickly and review this before moving on. So the first imaging modality we're going to talk about is the infamous head CT. You're going to see this on pretty much every patient who comes through the neurology service, usually ordered reflexively in the ED because they have neuro something going on, but it's really a common and important test to know. And this is because the non-contrast head CT is an excellent screening test. Really, that needs to be ordered anytime a patient has an acute neurologic change. The reason we do this is because the head CT without contrast is very quick. It's non-invasive and it can easily rule out dangerous processes that would change management, such as a bleed or a large mass, herniation, other things like that. As we'll discuss in the next few slides, it can also help you detect some early ischemia, but it isn't something we bank on. And then finally, it is probably better than MRI at imaging bone and soft tissue injury, although we use it less for that in neurology. If you notice in the last slide, I really focused that was a non-contrast head CT. As a screening test of choice, and so you're wondering when we would order a CT head with contrast, then the answer is honestly almost never. This is for a couple reasons. As we'll talk about in a couple pictures, contrast can easily mimic blood, and since we're often using non-contrast head CT to first and foremost rule out blood, this kind of defeats the purpose. The other issue with contrasted head CT is that the lesions that contrast enhance often are non-emergent lesions that we would just rather visualize with an MRI. So it's really worth just waiting to get your MRI if you're just looking for contrast-enhancing lesions, especially because these are typically non-emergent. Really, the only time you're going to see us ordering a head CT with contrast is when a patient would need an MRI to look for contrast-enhancing lesions, but they can't undergo it, say, because they have an incompatible pacemaker or something. What exactly is a contrast-enhancing lesion? And this is the same for CTs and MRIs. These lesions are where the blood-brain barrier is being disrupted, so it allows for contrast to leak out and cause enhancement. This is seen in a variety of diseases, but the most common ones are neoplastic, infectious, and inflammatory lesions. And then it's important to know also that subacute strokes can cause this at times. We don't use contrast-enhancing imaging to look for this, but you may see a stroke light up on a contrast-enhanced study, and I don't want to worry you. Back to bread and butter head CTs. So first thing first in understanding them is you need to know what's going to show up hyperdense and what's going to show up hypodense. Hyperdense objects which show up white are exactly as they sound. They're very dense. So this is thick objects, things like bones, calcium, metal. More importantly, though, it includes blood and includes contrast. And like I said, I'm going to show you in a couple pictures how difficult it can be to distinguish the two of those. And that's why we always order a head CT without contrast when evaluating for a bleed. Technically, if sometimes this doesn't happen, sometimes we get it with contrast, sometimes they've already had a CTA or a CTPA. And so you may have to tell the difference between blood and contrast. Technically, there's some fancy imaging software that can detect the number of HUs or Hounsfield units, which is a fancy physics term for how dense something is. And contrast should be slightly more dense, but this isn't always definitive. It's difficult to do, and it's just something to keep in mind. And then on the other hand, objects that are hypodense are objects that show up black on imaging. So this is things like air, CSF, and injured brain as well. As the cells are dying, there's less density, and so ischemia is going to cause hypodensity. But let's be honest, pictures are worth 1,000 words, especially in radiology. So let's look at some pictures. So here's some great examples of bleeds, which, as you can see, they're going to show up white on imaging because they're hyperdense. I'm going to have a different lecture where we'll talk about the diagnosis and management of these different bleeds, but from left to right here, you can see an intracerebral hemorrhage, or ICH, a subarachnoid hemorrhage, and a subdural hemorrhage. In the ICH, you see that the blood is located deep in the parenchyma of the brain, which is why sometimes we call these an intraparenchymal hemorrhage. In the subarachnoid hemorrhage, you can recognize it because it's trailing along the sulci and kind of snaking through them, as you can see here. And actually, if you look carefully, you'll see that the famous star sign, where the middle of the cistern supposedly creates a star, if you really squint, maybe. And then a subdural hematoma here on the right. Subdural hematomas appear on the outside of the brain. It's a crescentic shape like this. Remember that an epidural hematoma, which isn't pictured, is more of a lens or football-like shape. And then here's a good picture of how contrast can really closely mimic blood. So the top series of pictures represents contrast extravasation, which slowly regresses when you follow the pictures going from left to right, versus the bottom set, on the other hand, represents an intraparenchymal hemorrhage that actually persists throughout time. And the second picture in each of these series that's red demonstrates a difference in these using different filters for densities, but as you can tell, it's pretty subtle. Okay, and then on the other hand, here's some examples of hypodensities, which, as you'll remember, show up dark on CT. The picture on the left is of pneumocephalus, or a collection of air in the brain. Usually these are secondary to trauma or recent surgery. They can be congenital, though. And then on the right, you're going to see hydrocephalus, which is an increased collection of CSF resulting in dilation. And then, like I said, ischemic stroke also can be hypodense. And so let's talk about ischemic stroke and head CT. On the left, you'll see that chronic stroke here is often quite obvious, especially if they had a prior large ischemic stroke. And you're going to see a large area of hypodensity, and you may actually see encephalomalacia, which is cystic-like scarring and atrophy caused by prior damage. But acute stroke is a lot more difficult to pick up. And in fact, more than half of acute strokes actually are completely undetectable on head CT. And this is why we don't use head CT to rule in ischemic stroke. We use it to rule out bleeds or other contraindications of TPA. If you're lucky, though, you may see some early signs of stroke on head CT. So this includes blurring of the gray-white junction, which you can see here in the far right picture, kind of on the bottom right where it's a little darker and grayer there. And then if you're really lucky, you can see the hyperdense vessel sign, where you're actually visualizing the clot sitting in the vessel, and it shows a real bright white because it's so dense. And then this middle picture here is a great example of a hyperdense left MCA. Something that's a little more advanced and something that as a non-neurologist you don't need to really know, but it's something you're going to see us and neuroradiologists discuss, and it's good to familiarize yourself with, is the ASPECT score. So ASPECTS, or Alberta Stroke Program Early CT Score System. ASPECTS is much nicer to say. It's a grading system that we start at 10, and then we subtract a point if we see gray-white blurring in any of these areas here. If they have a high score, maybe like a 7, 8, or 9, this is pretty concerning for early ischemia, which should be acted upon. If they're getting towards the 5, 4, 3s, that means that this, though, is such a large stroke bed, and it's probably later in the course that it's going to be pretty dangerous to give this person TPA, and they're at great risk of hemorrhage with intervention. In order to look for aspect scoring, you're going to see us a lot of times window our head CTs to make them look much grainier. If you're really curious, we window it to like 30 by 40. But again, this is all stuff that non-neurologists don't really need to know, but just stuff that you're going to see us talk about. Okay, you're right. Aspect scoring was a pretty cruel thing to teach. So even if I don't love you, just know that Willow and Maisie definitely do. They love everyone, though. Okay, back to business. So In the next section, we're going to talk about vessel imaging, includes CTAs, MRAs, and then conventional angiography. First things first, though, take a look at this beautiful picture of the Circle Willis here. If you don't think the Circle Willis is one of the greatest masterpieces in the world, then we're going to have a talk. Anyway, though, vessel imaging in general is just really an integral part of any stroke or TA evaluation. I talk more about this in the stroke lectures, but it helps us both in the acute setting in determining if a stroke is present that needs to be intervened upon, or if a clot is present that needs to be intervened upon. And then also in the post-stroke setting, it can help you determine stroke etiology. Beyond this, though, it can help you evaluate for aneurysms, for example, in someone who had a subarachnoid hemorrhage, or who has a neuro deficit like a third nerve palsy suggestive of an aneurysm. Can help you look for vascular abnormalities, things like AVMs, venous thrombosis, stuff like that. So it's really great testing. There are three types, like I said, of vessel imaging: CTA/CTV, MRA/MRV, and then catheter-based angiography. So how do you know what test to order and when? So all three of them have their own pros and cons. CT-based vessel imaging is great because it's minimally invasive and it's a very quick study, so it's ideal for a code-stroke situation. And then actually what's surprising is it's actually more precise than MR vessel imaging. At first I found this a little counterintuitive because MRIs typically are more detailed than CTs, but this is because MR vessel imaging uses a lot of physics to evaluate flow. And so if your vessel is moving slowly, the image might believe that it's actually occluded and just overcall it. So often we see that MRAs overcall stenosis. Like all CT imaging, the biggest con for it is the immense amount of contrast associated with it. It's dangerous in patients with kidney injury or contrast allergy. And then don't forget the CTs are associated with a fair amount of radiation. Important to remember, especially in pregnant women. These are the pros of the MR vessel imaging mostly, is you avoid a lot of contrast and radiation. And in fact, MRAs and MRVs can actually be performed without using contrast at all. They just use physics again to measure the water molecules in the flowing blood, which if you ask me is pretty nifty. And then of course the downsides of MRI vessel imaging is they're slow, they can't be used emergently, they're prone to artifact, and they do overcall stenosis like we mentioned. If we compare both of these to catheter-based angiography, which is also known as digitally subtracted angiography or DSA, DSA definitely offers us the highest resolution of vessels of the brain, both arteries and veins, and they're really considered the gold standard of vessel imaging. Procedures performed by wearing a small catheter through the groin and into the vessels of the brain, similar to how they get a heart cath. And by placing this catheter internally, that we also are offered endovascular access and can really do a number of procedures, which I'll talk about later in the lectures. And then just last note, before moving on, if you see over here on the right, just always make sure that you order both imaging for the head and the neck when you're obtaining a CTA or MRA. There are separate tests in the orders, and they can be run separately by radiology, but really there's no reason on our service to not order one if you're ordering the other. So just please don't forget to do this, or you're going to be sending the patient down for a second image. Okay, so let's start with CTA here. So when we're looking at CTA, we typically start by viewing the axial cuts. Generally, we'll start caudally in the neck, where the primary vessels are rising from the aorta. So here in the top left picture, you can see an axial CTA of the neck, and you can actually visualize the two vertebral arteries back here. You can see the two internal carotid arteries here, and then the external carotid arteries here. And at this point, actually, it's always a little odd that the internal carotid arteries are lateral to the externals, but eventually they'll become internal. Another tip is you can see little branches coming off of the external carotid. The external carotid has branches, the internal carotid artery does not. And so I like to start at these, make sure you can see all these vessels, and you want to follow each one of them up, going all the way up to the into this Circle Willis. And then once you get into the Circle Willis, of course you want to follow all its terminal branches, and this is a good time to kind of use localization. And so if you see symptoms suggestive of a right MCA stroke, then you know you're going to be looking for a clot in this area, which is pretty evident there on imaging. And then finally, CTAs do offer reconstruction imaging, which you can see here at the bottom. These images are excellent at helping you conceptualize anatomy. They're good for understanding big picture pathology, but It's important to know they miss a lot of fine details. They're pretty prone to artifacts, so just use them cautiously. And when we use MRAs, we actually follow the same routine as we do in CTAs, starting at the aortic arch, following the great vessels all the way up to the circle of Willis. So again, here's a good picture. You can see the two verts back here, and then your carotid arteries here and here. In the top right, here's a picture of a beautiful MRV, which really demonstrates how good the MRV is. And MRV, at least, is usually superior to CTV. And then here in the bottom right, you can see a picture which demonstrates, or at least on the MRA, it looks like there's a complete occlusion. But then if you look at the same vessel in DSA, you can see the MRA is actually overcalling the stenosis, and the vessel is really only 80 or 90% occluded. So like we said, this is just an important concept to remember that unfortunately is one of the biggest downfalls of MRA. I'm going to stop here for now. Come back for the second part of the lecture where I'm going to go into more details, and I'll talk about DSA then, and then touch on CT perfusion, and then really hit on MRI and its different sequences. So we'll see you then.